Of the Senate Standing Committee on Families and Children for the 2024 General Session. Secretary would please call the roll.
Senator Chambers Armstrong, Senator Elkins, Senator Girdler, Senator Mays Bledsoe, Senator Meredith, Senator Tishner, Senator Webb, Senator Westerfield, Senator Wise,
Present.
Vice Chair Rocky Adams, Chairman Carroll.
Here. We do have a quorum. I would like to welcome Senator Chambers Armstrong to this committee. Welcome, and we are glad you are here. We have a couple bills on the agenda today, and we're going to move right into that. If Senator Shelley Funky Fromeyer would please sit at the table. Does anyone have anyone they'd like to welcome here this morning? Okay. The first bill that we're going to hear is Senate Bill 74. This is an act relating to maternal health. Senator, would you please introduce yourself for the record as well as your guests? You have the table.
Yes, thank you, Chairman Carroll, and thank you so much for calling this bill to our attention today. My name is Shelley Funky Fromeyer. I'm the state senator in Campbell County, Pendleton County, Bracken County, northeast corner of Kenton County. So it's basically Senate District 24. I'll have my two guests introduce themselves.
I'm Mary Catherine DeLoder with the Kentucky Birth Coalition.
I'm Dr. Robin Elise Weiss.
And thank you for allowing us to bring this to your attention. Senate Bill 74, the good news for me is I have a professor here at the table with me, as well as the leader of the Birthing Coalition. So they'll do a much better job than I could ever do, giving you the depth. But I did want to share that we have not heard any direct opposition to this bill, but what a couple questions that I wanted to acknowledge. You're going to hear a little bit more about the importance of learning why are these deaths occurring. And there is a panel currently that will gather and review how a death occurs, but it's not a requirement. This bill is actually taking it to that very important step, making it a requirement, so that we actually do dig in, understand, tackle the issue, and improve our health outcomes. Mom's safety, baby's safety is our maternal health initiative, and we're going to make this happen. So we want to share with you some details, and I'll hand it over to Mary Catherine.
Thank you. Many people know that Kentucky has a Child and Maternal Fatality Review Committee. The maternal mortality portion of that was added in 2018 through a committee substitute that was added to the House Bill 167 for that year. Prior to that, statute only referenced the Child Fatality Review Team. The current statute now says that the state may create these review teams. This bill, Senate Bill 74, changes this to shall, so that these teams are permanent. The Kentucky Maternal Mortality Review Committee was established in 2018, and it's a diverse group of stakeholders who review all maternal deaths in the state. The team produces an annual report that provides a great deal of information on maternal deaths in Kentucky. Data from this report has been presented to various legislative committees on numerous occasions and has been used to inform policy decisions and priorities. Senate Bill 74 does not change the work of the existing Maternal Mortality Review Committee in any way. This bill makes it so that the review committee is permanent by changing the may to shall. The bill also adds a definition of the state review team, and it makes a correction to the reporting requirements. In 2021, House Bill 212 was passed to add a requirement that the maternal fatality report include a demographic analysis by race, income, and geography. The Cabinet for Health and Family Services shared that they do not have the ability to track income data with regards to maternal fatalities. So the alternative that's proposed in Senate Bill 74 is to report any available information regarding Kentucky Medicaid or Kentucky Children's Health Insurance Program, or KCHIP, or other health benefits coverage data. This is data that is available and should be able to help achieve the intent that was in House Bill 212 as much as practically possible. And now I'd like to ask Dr. Robin Weiss to speak about Section 2 of Senate Bill 74.
I join you here today as a professor of public health, and I want to talk to you a little bit about the benefits of parents-to-be having access to data about hospitals and information as they make decisions about which hospitals to choose. So Section 2 has 10 upper-level categories of activities surrounding birth and pregnancy that make up 6 of the top 10 charges in private insurance and Medicaid. And parents-to-be have many decisions that they need to make about the birth of their baby. And yet healthcare is the one place they don't actually have really good access to really good data when it comes to making those decisions. There's no comparative data, there's no individual data, and in health in general, they struggle in this category. Having access to information about the rates from various hospitals will allow patients to be able to quickly figure out which hospital facility will best meet the needs of them and their baby. The National Partnership for Women and Families says of this type of information that decision aids and other tools to help women obtain safe, effective care aligned with their individual needs and preferences is critical. Right now, if someone wants to know a hospital's cesarean birth rate or induction rate, they may actually have to call the hospital. Who knows that information? Certainly not the person who answers the phone. Maybe they make it to the labor and delivery unit. That nurse that answers the phone may not know that information either. In the Commonwealth, if a person is interested in having a vaginal birth after cesarean and is looking at 2 different hospitals, the difference in the vaginal birth after cesarean rate in those hospitals could be 29 times different from one hospital to the next, and they have no way to know. If they currently go on a hospital tour to take the time to put in the effort to try and find out that information, what they can tell you is what color the bedspread is and what the flowers are on the wallpaper, but they can't tell you anything about the health care that is delivered in that hospital easily. Families in Kentucky can't get this information, and these decisions have huge financial implications not only for the families, but private insurers and Medicaid, and also have to do with the wellness outcomes for them and their baby and future pregnancies. Parents-to-be are used to quickly being able to compare services in so many categories. I also work as a birth doula, and I hear from them every week how they simply wish that they could quickly and easily find out information to help them make a decision about which hospital to give birth in. You shouldn't have to spend hours on the phone or dig through mounds and mounds of data from multiple websites or to submit data requests at various entities. Essentially, you shouldn't have to have a PhD to be able to get this information. Families want to make good decisions for the birth of their baby, and these decisions start with good data. And that's what Senate Bill 74 provides these families.
Thank you. We would welcome your questions.
On the bill, and I know with the Child Fatality, Near Fatality Review Panel, there are times that we have difficulty getting the information that we need, reports, things of that nature. With this legislation, does it address that, or what is the structure set up, and who will the information come from, and are all those processes in place already?
So what Section 2 of the bill addresses regarding certain pieces of information, which Dr. Weiss just spoke about, those are specific items that would be data that would be pertinent to hospitals, different types of intervention data, things like cesarean rates. So that wouldn't be anything that would be pertinent probably for the Child Fatality Review Committee. This is all data that the cabinet currently has available from various sources. So we did have the bill drafter check with the cabinet when this bill language was originally drafted to make sure that all of the pieces that are listed in Section 2 are available. And so it was confirmed that these are things that are available to be sourced, if you know. So I don't think that it would impact what you were asking about.
And help me understand how far this panel will go. I know with what we do in that panel, if there is a death, I mean we pick that up, and it's not automatic with every death that occurs. It depends on the circumstances, and those cases are screened out. So will this panel address do an inquiry into a death if it's the mom or the child? I guess I'm a little confused on how far this panel will actually go.
So this does not change the structure or the scope of the existing maternal mortality review committee or the child fatality review committee. We have them, but they are optional. So it is saying these are going to be permanent. So the current committees in their current scope would continue. There would just be no option. If for some reason the state decided they were going to discontinue it in the future, they would not have that option. The Maternal Mortality Review Committee reviews now all maternal mortalities, I believe, regardless of the cause.
Okay. Senator Meredith.
Thank you, Mr. Chair, and thank you, Senator Franklin Fromeyer, for presenting this bill this morning. I don't have any problem with the intent of the bill. I guess my question is more on the kind of the logistical side of it. And I'm looking at page 1. At the very bottom, it says the duties of state team shall include, but not be limited to the following. Then it talks about a model protocol for local child and maternal fatality response teams for investigation of child maternal fatality. So we've got this data, and we understand there's a problem, and we're going to develop a local team. Who's involved on those local teams, and where is this initiated? Is it the local health departments, or is it in concert with local hospitals? Or because you got a shall, and I certainly understand that, but there's really not a shall portion when it comes to development of these local teams. So can you tell me how that might work?
So the shall is with regard to the state teams, specifically there on item number 3 at the bottom of the page, the duties of the state team. That may to shall is for the state team, which the state teams already are in existence.
Well, that's my question, though, is I understand the intent of making this a shall and certainly support that, but I'm more concerned about how the next step looks in developing these local teams. Those local teams, that's not a shall. That's not in there anywhere. So I'm just trying to understand the composition of the local team and where the authority is for them to take action on whatever information they receive. Because as it appears now, you've got the state team, which becomes that shall. They have the data. What do you do then?
I don't think that it's changing, from may to shall in terms of the local teams, or at least that's not the intent. So however the local teams are structured now, where they exist, they may not exist in all places. This would not change anything with regard to the local teams, is my understanding.
Well, again, I appreciate that, and believe me, I'm not trying to be argumentative, just trying to understand how this is going to work. How will they unveil, so to speak, those local teams? Again, you identify the problem, you go to the community, say you got a problem. Who are they bringing to the table, and how they're going to bring to the table, and who's going to be the leader of that local effort?
From the way I read this, Chairman Meredith, it looks like that it's the state team shall be responsible to distribute a model protocol for the local. So the way I read that, it'll be the state teams. It's the state team's responsibility to set up the protocol for the local team. So they would be responsible for the structure and the functioning of those local teams.
But there's not a shall for the local team, though. And again, it's not a criticism of the bill. It's just it looks like it's a little bit thin on how we convey this information and how we move forward on it. Because you get that protocol, you can go to the community and say, yeah, we've got a problem, but you can't develop a team.
Senator Meredith, I perceived, and perception doesn't mean that it would be interpreted the same, but on page 3 of 5, in section 2, it would be line 24B in 1, that the cabinet shall utilize only national quality indicators that have been endorsed and adopted, and then taking that information on the next page, providing those linkages, but that it keeps the control in the cabinet's hands to coordinate statewide, but then working with a local, but it stays in ownership or control by the state. So whether they would then press certain expectations to get the local information that they're not able to get from their statewide database in order to get that specific incident or that specific, but bringing it back to a commonly available place that could be accessed to make the comparisons. Because I think that's the ultimate goal, is being able to find the information, find the issue, report on what issue may have occurred, and then get the results back into a commonly available place. But the local team is maybe going to be supportive, maybe not, but the state's going to manage.
And that's my concern, Senator, is that it may be supportive. We collect a lot of data that we do absolutely nothing with. And again, not criticizing the bill, but I see a hole here in that to try to get results. I think there's got to be a little bit more structure here, and I don't know exactly what that looks like or how to do that, but it's just a concern of mine.
And I'm eager as you on that accountability piece, and the one that I feel I've learned in my sophomore year now, that the state families and children seems to be the one that we can hold the most accountable, because they are a member of our team as well, whereas it might be more difficult to hold the hospitals to participate, but the state they shall do their darndest to gather this information and then put it in a place that can be more easily seen. That's my trouble, is I can't easily, as you know, I'm a mom, but I'm a grandma, and we just had 3 grandchildren in the last 4 months. We've been eager to report and understand the differences of one offering over another, and it's been difficult to find. So I was kind of excited to bring this bill forward, because it does put a little bit more structure and requirement to get that information in a searchable place. And as you said, there's tremendous amounts of information, but having it assembled or assimilated in a place that the average financial advisor or the average pregnant family can compare their options within their region, it's not so easy. So we're putting this shall on the cabinet's shoulders.
Again, have no problem with that. It's just that next step. And I would think, since it's going to be a responsibility of the Department of Public Health, then at the local level, should the leader of this initiative be in the local health department, that they become responsible for kind of putting together a team. Again, this probably had to be volunteering itself, but just that's where I see the shortfall is we do it at state level, then what happens? So, maybe we go ahead and pass this and we work on something next session, get a little bit more structure, but that's my concern, is that it gets to the state and...
I appreciate that. Yeah. With your knowledge and experience to identify possible hole that we have, would love to fill that gap.
What becomes
Because it's
everybody's
essential.
responsibility becomes nobody's responsibility, and that's my concern. If we don't identify what the organizational chart of this looks like, then I'm not sure we'll be successful.
The accountability chart.
Yep.
Yeah, I'm with you. Thank you.
All right. Thank you, Mr. Chair. Appreciate your indulgence.
Okay, I'm sorry.
I just wanted to jump in a minute and say to Senator Meredith, one of the reasons that it is difficult to always name a local entity is because there is not always a local health department in each county. And therefore, by naming specifically health department or various entities, we may hamstring the state level committee by there not being a local. So I would behoove you, if in future iterations, if you're looking at that, to give examples of who might be on that committee, as opposed to saying it has to be this, or this. We have, I believe 80% of our counties are maternity care deserts, and that makes it really difficult for us to be able to name specific people in specific counties who might be at that local level, or thinking about how we define local level.
May I respond, Mr. Chair? Again, I appreciate the point, but unless you've got a designated local leader, so to speak, I'm not sure who you hand this off to. This team and state team is going to have to go into these communities and say, we've got this issue, who's going to carry the ball for this? And that's not well defined. And particularly this day and time, with the shortage of healthcare providers in rural areas, this is another task I just can't take on. And where do we go from there? So again, my concern is collecting data and never do anything with it. But again, not critical of the intent of this bill. I understand it. Just trying to get some strength to it and make sure we get some outcomes.
Yeah.
But maybe not every community has a public health department, but I think the majority do. So it could be public health department or. So
Thank you, Senator Meredith. The other piece I wanted to acknowledge as well on page 2, this was a piece that brought me a lot of comfort because I serve on that interim joint committee on health services, but that on line 13, section 4, the department shall prepare an annual report to be submitted no later than November 1st of each year to the governor, to the interim joint committee on families and children, the interim joint committee on health services. That was added. But I really appreciate that because I do recognize we're trying to work on a holistic delivery system in Kentucky, and that does address so much within our health services, joint health services, but it does give us the opportunity, and I hate to sound crass, but to keep our families, our Cabinet for Health and Family Services accountable to the outcomes that we're trying to legislate in a healthier Kentucky, not just health care, but a healthier Kentucky. And I see some real benefits in getting information flowing and then give us a report on this at the latest November so we can see whether it's making a difference.
Mr. Chair, may I reply, please?
Yes, quickly, please.
Again, I appreciate the report, but you're also a member of Health Services Committee meeting. You know how many reports we receive during the course of a year. So again, we collect the data, we do the reports, then they go in this black hole that we'll never see again. So it goes back to my original contention of this. You got to find some structure on the local level in order for it to be effective. This is probably a great first step. I would certainly support it, but again, just sharing my concern about what happens going forward. I don't want to collect data just for the sake of collecting data.
Yeah.
Thank you, Chairman Meredith. Senator Wise.
Thank you, Mr. Chairman. Senator Meredith, thank you for your comments. And Senator Funky Fromar, thank you for bringing the bill. There's a lot of young people here in the audience, a lot of interns. You're seeing the beauty of the process right now, and especially the committee process of going through legislation such as this. I would also follow somewhat of a lead of Senator Meredith, just saying, I think the bill should pass out of committee. I'm going to vote for it. But I do think that this is also the part of the process of where those right now negotiating for what you want in this, also to get with Senator Meredith and others that may have concern. We're day 20 of a long 60-day process. My wife reminded me this morning, day 20 you're on. So with that, I think that if some things can be worked out, if there's still some concerns as the bill moves forward through the process. But I appreciate the dialogue this morning. And I appreciate everything that you've brought to the bill, and I appreciate Senator Meredith's concerns coming from his background as an administrator of a hospital, and also the role that he's played in his community and knowing that at the local level. So, Mr. Chairman, I'd like to make a motion on the bill. I know we have another bill on the committee today, so I would vote a motion on 74.
Have a motion second from Chairman Meredith. All those, Secretary, please call the roll.
Senator Rocky Adams. Senator Chambers Armstrong. Senator Elkins. Senator Girdler. Senator Mays Bledsoe. Senator Meredith. Senator Tishner. Senator Webb. Senator Westerfield. Senator Wise. Chairman Carroll.
Aye. Senate Bill 74 passes with favorable expression on a 7-0 vote. Congratulations, Senator. And I think the goal is to put this in a package that is going to be usable. And that's the structure that I feel like you need to build around the data to make sure that it's not just something that's there, but it's accessible to those who need it in a format and it's accurate data that is valid throughout the entire state.
Thank you.
The second bill that we have on the agenda is Senate Bill 89, and this is an act related to Medicaid coverage for certified professional midwifery services. And,
Thank you. We have a few guests that will be joining me. I'll have them introduce themselves.
Ladies, please introduce yourselves for the record.
I'm Laura Browning.
Hi, I'm Sarah Hood.
Thank you, Chairman Carroll and dedicated colleagues. We're going to share a little bit with this bill about innovations in healthcare. The old is new again. After 100 years, we want to apply some of what we learned and those experiences, allowing women who are really striving to take control of their health outcomes to also have an opportunity to have a woman with you. Families are really managing their costs while they're pursuing excellent health outcomes for the mom and the baby. How does a holistically, physiologically natural process strengthen your mind, your body, and your spirit? Well, we offer that if having a woman with you, which is a licensed midwife, you achieve the birth of a child successfully, that feels beautiful to your mind, your body, and your spirit. Our goals are to improve safety and health outcomes for mom and baby. This care to mom relies on teaching mom from prenatal to postnatal to care for herself. That's the care model. Often this care is offered in a smaller home setting that has relieved mom and newborn from the exhaustion and the challenge of travel back and forth for office visits. Costs may be dramatically reduced from what our taxpayers are currently helping to support via the Medicaid process. Thank you for this opportunity and for giving our presenters your attention.
Thank you. For those of you who are also members of the Health Services Committee, you heard about this topic during the interim at the State Fair meeting. At that time, Representative Russell Weber was at the table presenting this bill. He's carried that bill last year, and also want to acknowledge Representative Nima Kulkarni, who's here this morning, who's also carried this bill along with Representative Weber in the House in the past. And thank you to Senator Funky Fromeyer for picking this up with Representative Weber's departure from the legislature. First, I just want to add one piece of clarification on this topic. There are two types of licensed midwives in Kentucky. We have APRN certified nurse midwives, and we have licensed certified professional midwives, or LCPMs. And so today we're specifically discussing licensed certified professional midwife, LCPM. LCPMs are primary maternity care providers who deliver comprehensive perinatal care, including complete prenatal care, labor delivery services, and postpartum care for the mother and baby through 6 weeks after birth. These are not laypersons, but trained professionals who hold a national midwifery certification as well as a license in our state. LCPMs attend the majority of planned home births in the Commonwealth. Although LCPMs are not nurses, the legislature tasked the Kentucky Board of Nursing with overseeing this credential, which was passed in 2019 with Senate Bill 84. Every current member of the Senate who was serving in the Senate in 2019 voted yes on the final passage of that bill to license certified professional midwives. So I know many of you were here then, some of you were not. There are now 32 licensed certified professional midwives around Kentucky, and that number is increasing, and we also have quite a few LCPM students who are on their way to becoming licensed. There are currently 36 states plus the District of Columbia that have licensure for CPMs. 5 of those have come about since Kentucky passed this in 2019. There are now 18 states, including plus DC, that have implemented some form of Medicaid reimbursement for certified professional midwifery services. Senate Bill 89, this bill, would add Kentucky to that list that would cover LCPM services. While not everyone will choose a home birth, we believe that all maternity care options should be available to all healthy women. Currently, those on Medicaid in Kentucky who wish to have a home birth have one option. There's one APRN nurse midwife in the state who attends home births, and you're going to hear from her in just a few minutes. If someone happens to live in the service area of this midwife and they have that specific MCO that she works with, then they are in luck. However, the vast majority of planned home births in Kentucky that are attended by LCPMs, not nurse midwives, and therefore they cannot be covered by Medicaid at this time. So we see people doing one of the following things in some of these situations. They either forego the care that they truly desire and they plan a hospital birth, which is covered by their Medicaid plan. They may make sacrifices and find a way to pay out of pocket for a birth with their LCPM and not utilize their Medicaid coverage. Or they might choose to have a home birth without a trained provider or on some occasions without any provider at all. Choices in childbirth should not be limited to those who have the ability to pay out of pocket. Over the past 2 years, the topic of LCPM reimbursement has been on the agenda of the Advisory Council for Medicaid Assistance, or the MAC, as it's commonly known, numerous times. The technical advisory committees, which are like the subcommittees of the MAC for both nursing services and for the consumer rights and client need, have both recommended to the MAC that LCPM services be reimbursed by Kentucky Medicaid.
Motion on the bill.
Is there a second? And I'm sorry to cut you all off. My understanding from conversations with Secretary Friedlander, this is likely coming down from the feds anyways. I think he's about 90% sure that it's going to be required of the states. So I think we're going to go ahead and move forward. We have a motion and a second. Secretary, please call the roll.
Senator Rocky Adams. Senator Chambers Armstrong.
May I briefly explain my yes vote, Mr. Chair?
Please proceed.
I vote yes. Aye. I think this is a wonderful bill. Thank you so much for bringing it forward. The numbers that stick with me are that 90% of maternal mortalities are preventable, and that the reason they're preventable is not because we need fancy interventions or more high-tech care, but we just need basic access to care, and I believe this bill would do that, and so I'm proud to vote yes for it.
Senator Elkins. Senator Girdler. Senator Mays Bledsoe. Senator Meredith.
Explain my vote, please.
Please proceed.
I'm an aye on this. I would like to know if there's a fiscal note on this, since we're adding a new kind of scope of services to Medicaid. And again, this goes back to we offer a wide array of services in the Medicaid program. And I don't think we have a single one that's adequately funded at the present time. So I'd just like to know what the fiscal impact of this could be upon the program. So,
Yeah, from the discussions I had with Secretary Friedlander, I think there's expected to be a savings because of these services being much cheaper than delivery at a hospital. And I think that's kind of the way they were looking at it.
well, I'd hope he could identify that so we could shift those savings to other
Absolutely.
programs. But thank you.
Senator Tishner. Senator Webb. Senator Westerfield. Senator Wise.
Aye.
Chairman Carroll.
Aye. On a vote of 7-0, Senate Bill 89 passes with favorable expression. Senator, congratulations. Ladies, thank you for being here today, and I apologize again for cutting you short on your testimony. That is the final bill that we have before the committee today. And if there are no questions or comments, I will entertain a motion to adjourn. So moved. We stand adjourned.
Signed by the X. Sir? Thank you, sir. And then just coordinate with me about next week's.
Excellent.